You guys are very lucky today because you have a time limit to me. This is a topic that I could talk about for 8 hours, but you have a 1 hour period. So I'm going to give you a brief overview about testing, some of my interpretation tips, and some of the pitfalls that you might look or run into if you're looking at outside results or if you're doing the testing yourself. So basic agenda, I'm going to do some basic interpretation. We're going to talk about the sections of the V&G. We'll do some caloric interpretation and major pitfalls for calorics. Talk a little bit about the balance testing, our postural testing, rotary chair. And then if we have time at the end, we'll talk a little bit about adaptations for pediatric testing and maybe a couple case studies. So when we talk about basic interpretation, it's important to go back to the basic eye movement systems. When we do vestibular testing, we're looking for two things. You're looking for the eyes to move when they're supposed to and not move when they're not supposed to. So we do check parts of the oculomotor system. So you think of the 6 eye movement systems, and you can break those down into 2 types. There is the section that holds images of a target steady, such as fixation. You think gaze with fixation. The vestibular system, that vestibulo-ocular reflex, which holds the image steady during head movements, and the optokinetic system, which holds the image of a target steady during sustained head movements. Then there are also those that direct the eye onto the object of interest. So the CCC-A system, the smooth pursuit system, and vergence, where the 2 eyes move in opposite directions so that the images are held into focus on a single object. That the brain kind of taking those 2 images and making them one. So in vestibular testing, for the most part, you're looking for the presence or absence of nystagmus. So nystagmus is a normal response in some test conditions like calorics and rotary chair, but abnormal in other conditions, such as during pursuit tracking or during positional testing. Nystagmus is defined as an involuntary rhythmic motion of the eyes that consists of that slow drift in one direction with the fast correction back. And when we were initially naming nystagmus, this was before tracings. This is when we were just kind of looking at the patient. We started naming nystagmus by the fast phase. So that is the beat, the way that it's beating. So you would call a right beating nystagmus or a left beating nystagmus. But when we talk about speed, or if we gave it a number, the velocity is defined by the slow phase. So we measure the drift of the eye away from the target in degrees per second, and then we name it by the beat back. So I think it's interesting to say you can calculate this by hand with a ruler if you needed to. That's the way it was done initially with a protractor and averaging things together. However, now it's typically computer calculated. So when you're looking at a tracing, almost all vestibular testing systems are going to break your tracing down into 2 parts. There is a horizontal tracking and a vertical tracking. A lot of these systems too will summarize for you up in a corner what the nystagmus is. So this was a left beating nystagmus at about 5 degrees per second. So when you're learning, I think it's sometimes hard to remember left versus right beating. Up and down is a little bit easier. You see the drift up and then it beats back down, but left versus right is sometimes harder to keep straight. So what I tell learners is if you put your arm up to the slow phase of the nystagmus, this is the slow phase here. I'm matching the tracing and it's a left beat nystagmus. When we talk characteristics of nystagmus, there are quite a few different characteristics of nystagmus. A lot of them we won't necessarily see in otologic cases, but it's important to know how to describe it. So there's pendular versus jerk nystagmus. Pendular is more of a back and forth. You can name the plane that the nystagmus is in. So is it a horizontal nystagmus, vertical, torsional, or combined, like a rotary or elliptical nystagmus? And as a callback to that last slide, our V&G equipment, all equipment currently does not take into account torsional or elliptical, like a rotary nystagmus, because it's broken down into a horizontal component and a vertical component. So that's when it becomes important to make sure that you have video recording as well. When you talk about nystagmus, you can also talk about conjugacy. Are the eye movements conjugate? Are they disconjugate? Is the disjunctive, is one eye kind of drifting off? You can talk about the amplitude. So how large is the beat? You can talk about the frequency. How often is it happening? Or you can talk about the slow phase waveform. So this means nystagmus that is increasing in speed over time or decreasing in speed over time, or is it a constant velocity? So when you think spontaneous nystagmus, you're usually thinking constant velocity. But when you're thinking BPPV, like in a Dix-Hallpike, typically that nystagmus will kind of ramp up and back down, and that's a characteristic pattern. So we call that a crescendo-decrescendo pattern. So it's important to look at the waveform as a whole rather than just one little tiny snippet. So when we talk about the sections of the VNG, that is a very classic definition. When I am giving these lectures, if it is in bold and italics, that means that I've taken it from the board review book word for word that I'm going to show you at the end on my references slide. So I like to read the portions of that out loud. So how is ENG or VNG useful in the evaluation of the dizzy patient? Nystagmography comes in several forms. ENG implies electrodes only during that recording. So most places are not doing electrodes only. Most places are doing VNG, video nystagmography. And it serves to quantitatively measure eye movements while performing positional testing or calorics. And then again, this is our reminder, video must be used to supplement any time that you are using these tracings. So VNG can be broken down into three sections. You have ocular motor testing, you have positioning and positional testing, and we'll talk a little bit about the difference between the two of those, and then classically caloric testing as well. So ocular motor testing is broken down into gaze with fixation. So this is gaze with vision enabled. They're focusing on a target. You have smooth pursuit tracking, and that's at various speeds. It gets faster as it goes along. Formal saccade evaluation, where you're looking at velocity, latency, and accuracy, and then optokinetic testing. When I talk positional versus positioning. Positional implies that you are holding a static position. So this is holding that position in regards to the gravitational vector. So are you on your back? Are you on your side? There is also some cervicogenic or muscle or neck muscle movements. So you may be on your back with your head tilted, or you may be on your back and rolled over onto the left. There is still some debate about how much positional nystagmus is seen in the normal population. So I will say in the hundreds and hundreds of patients that I have seen, quite a few people have positional nystagmus without any other findings, and it can be quite robust. There is just that kind of bell curve, just like there is for anything else. It's only of minor diagnostic utility. Positional nystagmus is not a lateralizing finding, and in a lot of ways is not even a localizing finding. It could be helpful to determine if the nystagmus fixates or changes directions, because if it fixates, then you think more peripheral. If it doesn't suppress with fixation, that would be more of a classic central finding, particularly in vertical nystagmus. And then I throw in the mention of PAN. I think most people have heard about positional alcohol nystagmus, but that's in a very particular pattern. So you may run across that pattern at some point. When we think positioning or rapid positioning testing, that is traditionally what we think of as BPPV testing. So classically, this would be your Dix-Hallpike maneuver or your body roll testing. And here's our next board review question. With the patient sitting, rotate the patient's head by approximately 45 degrees to the left or the right, depending on which canal you're trying to test. The patient then lies flat with the head slightly extended, approximately 20 degrees. The eyes are then observed for 45 seconds, looking for rotary nystagmus. If rotary nystagmus occurs, the test is positive. The direction of the fast phase reveals the site that is affected. So in a positive right Dix-Hallpike, you would see right and up rotary nystagmus and that crescendo-decrescendo pattern. It's very robust. It's very easy to see in room light. When we talk about BPPV, that benign stands for peripheral, can be treated. Paroxysmal means a brief violent outburst, and this is a very violent outburst. A lot of the times these patients are very symptomatic in that position. But because it's related to gravity, it's related to those otoliths moving. It is very brief, works its way up and back down within usually about 30 seconds to a minute. It's a positioning test. And typically these patients do have a sensation of vertigo, a sensation of spinning. In our elderly population, sometimes that is just a lightheadedness perception, but typically the symptoms that you're going to ask for are for a sensation of spinning with head movement. And then the third part of the VNG is caloric testing. So thermal caloric testing measures the responsiveness of the horizontal semicircular canal and the superior vestibular nerve to thermal stimuli, and is one of the few quantitative tests that can assess the two ears independently. So it does not assess the other two canals. It doesn't assess otolith function. And this is an ultra low frequency response. So when you think of rotary chair, which we'll talk about later, this is a lower frequency response than the rotary chair. So you can think 0.001 to 0.002 hertz. So this is my little soapbox moment here. Air versus water calorics, there are pros and cons to each. We use water here. Some of the pros to water is it's a more consistent or reliable stimulation. And the nice thing with water is that water is going to rinse down and it's going to cover the whole TM at the same time. For air, you need to hold that tip very, very steady into one spot, or the temperature transfer is inconsistent, so you won't reach the same kind of peak. And for that purpose, air has more extreme temperatures and it takes a longer irrigation. So for water, we use a 30-second irrigation. For air, we use a 90-second irrigation to make sure that we have reached that temperature inside. The patients also tend to better tolerate water. It does have a stronger response, so they're a little more symptomatic, but it's less painful than having kind of an otoscope tip shoved in your ear. And the temperature being less extreme is a little more comfortable. So we have probably all heard of Robert Barony. He first described the caloric response in 1906, and this was a key observation made while he was irrigating out some rumen. So that's kind of just a little pearl to keep, because everyone always asks, well, this test is crazy. Who came up with it and how long have you been doing it? So we've been doing it around 120 years. So key facts. Cold will cause the fast phase of the nystagmus to beat towards the opposite ear, whereas warm causes the fast phase to beat towards the ipsilateral ear. You can think cows, cold opposite, warm same. When we do caloric interpretation, we have two different numbers that we get from it. Traditionally, you think of it as a unilateral weakness, so calculating the difference between the two ears, but you can also calculate a directional preponderance. So which was stronger, the warm response or the cool response, or which was stronger, right beating nystagmus versus left beating nystagmus. You can also report on the total response or the sum of all responses, just to talk about the overall responsiveness of the system. So what is significant? In our clinic, we use 25% or greater unilateral weakness as significant, 30% or greater directional preponderance. So if you have a higher directional preponderance than that, you may think central. However, what you need to make sure is that you do not have any tester error or uncorrected spontaneous nystagmus. So if you correct for the spontaneous nystagmus, typically your directional preponderance will also correct. So I have seen maybe one or two who have actually abnormal directional preponderance out of the last 10 years. Once I've done all the corrections, once I've made sure that all of the tracings look appropriate. You want to consider the presence of your outliers, and there's also an order effect on calorics. So the first irrigation tends to be the strongest. So as time goes on through those different irrigations, the fourth or the fifth, if you have to repeat something, will typically be the weakest response. And then warm responses are typically more robust than cool, particularly for water. When we talk about the results and how they're displayed on the testing or the tracing, there are two different ways that they're displayed. They can be displayed in a pod. So this is all beats are graphed onto a chart in a crescendo decrescendo fashion. We'll show you that in a second. This shows the raw data, the peak and the fixation suppression. And this looks like a curve or a pea pod. You can also graph it as a butterfly, and this peak is represented numerically on a graph, and the center of the X is where you're looking. Is it inside the box or is it outside abnormal? So this is a very easy visualization. It's important when we're doing any testing to edit outliers, but particularly for caloric testing. So common pitfalls or common causes of outliers would be that the eyes are closed. If the patient's eyes are closed, you can't record the pupil movement. Excessive blinking, we use infrared cameras, and the camera uses the darkest part of the screen to put the crosshairs on. So if they are blinking and they have dark eyelashes, every time they blink, that crosshair is going to wander off of the pupil. Sometimes patients will have their gaze off center, or they will wander their eyes back and forth, or even if they move their eyes to the extreme against the nystagmus. What we know about nystagmus is if you look against the nystagmus, you can suppress that nystagmus a little bit in speed. So we're going to go into some cases to illustrate some pitfalls. So this is a 50-year-old male. He was referred for ongoing dizziness, symptom onset 3 years ago. He describes his gait as a drunken gait, and he's fairly constantly lightheaded. So outside ENT testing, big take home here was caloric responses were noted to be normal and approximately equal bilaterally. So they called it a normal ENG. So this is the outside butterfly. So if you look at this graph, you have your eye speeds of 20 and 20, 20 and 40. And then this breaks it down towards the side. We've got a 9% caloric weakness without any symmetry. It falls right inside of that normal box. So we repeated this testing because we knew about the raw data that you're about to see. When we did testing, he had left beating spontaneous nystagmus. That was in 11 out of 11 positional testing. Fine left beat nystagmus post head shake, negative Dix Hallpike. He had increased phase in rotary chair, but he had normal SOT. So this is what our caloric responses looked like. So we have a significant asymmetry here of 53% weakness, which matches that case history. Speeds are 30 and 19, 8 and 7. So this is our pod. So if you look, it tells you when you started recording towards the end. And classically, a caloric response is going to reach up to a peak and then go back down. So you can see our pods in the right ear, nice big pod, very nice and smooth. You see a clear peak with a clear lowering of response as time goes on. And then on the left side, we don't see this same pattern because there's not as much of a response, but we have marked a peak here. And both of these peaks are about the same time. That's something else that you can look for. If the computer is marking a peak here and a peak here, time-wise, I would think we probably need to clean up that recording. That doesn't make logical sense about temperature transfer. So again, here's the outside calorics with their 9% right weakness compared to our 53% weakness. And then this is the raw data. So this raw data here, what you see is some very clear outliers. So the computer, this little box is what the computer has picked as the peak. And it looks like the clinician did not clean up this recording. So this peak's a little high, this peak's a little high. I would probably put it right about here and here. But what you see on the left side is that the computer has picked clear outliers as the peak. So rather than the peak being about 10 would be my guesstimate and about 6 or 7 here, the computer has picked 40 and 20 because it's picked an outlier. So that's why it's so important to look at both the raw data, look at the pods, and look at your tracings as well. So we have another case here. This patient is 55, has a history of sudden attacks of high blood pressure coupled with dizziness. Attacks occur approximately every 3 months. Daily episodes of vertigo coupled with imbalance, nausea, and lightheadedness. So outside ENG says caloric responses were normal and approximately equal bilaterally, even though they note positional nystagmus. Outside ENG, very similar to the last one, a 9% left weakness, and then responses in the high teens, low 20s. So outside calorics, same thing here. So we have a lot of outliers that the computer has chosen, or even the clinician may have chosen, whereas we see that the majority of the responses are quite a bit lower here. The other thing to keep in mind here for this patient is this was air calorics versus water calorics. So we're going to bring them back in and we're going to do some water calorics. So our VNG, no spontaneous nystagmus, no post-head shaking nystagmus, but there was right or right and up beating nystagmus in 6 of 11 positions and in both Dix-Hallpike positions. And then there was increased phase in rotary chair, which tells us something is going on with the system. These are our caloric responses. So we again finally have that nice big pod up and back down, pod up and back down on both sides. And we have a 37% weakness, which tells us that something has happened to the left ear, that there is that reduced response. And we've also corrected for the spontaneous nystagmus to keep that directional preponderance down low at 12%. Case number 3, we'll just run through it again, mostly to look at that raw data. Sudden onset of imbalance, May 2014, following herpes zoster infection. Outside VNG said VNG is abnormal. Bilateral caloric weakness is non-localizing. So their outside responses for air calorics were low, very low. The total eye speed here is under the cutoff for a bilateral hypofunction. They still said that there was no unilateral weakness. I would argue when your responses are so low that you can't really quantify a unilateral weakness, that you need a more robust response to quantify a unilateral weakness. And then they have a low directional preponderance. So the directional preponderance is within normal limits. So when we did calorics here with our water calorics, we actually had pretty robust responses on both sides, but we found a unilateral weakness. So we have 15 and 18 in the right ear, 59 and 46 in the left ear. That's a pretty drastic difference between the numbers that were all below 10 on outside testing. So they have a very normal total eye speed, but they have a right-sided weakness, which would correlate to the herpes zoster infection. And then I have one more example here that just shows an outlier. So you have 3 responses that all look very similar. You've got a 28, a 27, and then this cool that is weaker than the warm, which is what you would anticipate just based on the pattern of things. But then you have a cool response that is stronger than all 3 of the other irrigations. So 37 degrees per second, you got a stronger response. It tells you probably got a better irrigation for that one. When you have an outlier, it is certainly worth going back and checking some of the other conditions, whether you do, maybe you try the cool in the right ear to see, 28 versus 37, or I would probably repeat the warm here because the 27 versus 8, that's a difference. So they did a 28% right weakness was their calculation, but we don't know what that would have looked like if they had gone back and repeated the low irrigations. So the reason to avoid pitfalls is just to recognize that there are technical issues in this testing, and there are patient-related factors such as cooperation or tasking or anxiety. Tasking is asking the patient to answer questions or to play naming games. It gives them a little bit of a distraction. It brings out a stronger response. And these can all alter the outcome of the data collected and thus the test. So it's not just tester error. Sometimes it's patient cooperation as well. And then just like anything else in medicine, you always want to consider the cross-check principle and case history. If you get caloric responses that don't make any sense related to the case history, consider looking further at those tracings or those outliers, or consider using water calorics versus air, or adding on an additional test for cross-check such as Rotary chair. Big picture, you just want to identify normal findings as abnormal, or you don't want to identify normal findings as abnormal. You want to identify abnormal findings as abnormal and normal as normal. Other common pitfalls for calorics, you want to perform otoscopy and cerumen removal prior to irrigation. So we've found that even if there is maybe a 30 to 40% coverage or occlusion with cerumen, that can impact our water calorics. Air calorics are even more sensitive, so even a small amount of wax can affect your ability to position that tip. You want to make sure that the patient understands the test protocol, and more importantly, verify that the pupils are visible on the monitor prior to each irrigation and during recording. Did those goggles slip? Are you still able to see the eyes? Is the patient closing their eyes during the whole recording window? And then carefully edit your raw data tracings before you identify a peak, and then correct your raw values to account for any pre-existing nystagmus that you recorded in the baseline position. So I'm going to move on to balance testing now. So in our clinic, we have a couple of different balance tests that we routinely do. One would be computerized dynamic posturography. This is the classic piece of equipment. You see the picture down there with the little girl. I think most people have seen this piece of equipment. So this is a method for assessing upright balance function. When we think about standing upright, when we think about keeping upright, I tell my patients we have 3 main systems that work together: our eyes, our ears, and the information we get from our feet. So this computer system is the only test that I do that really looks at feet or ankles because I'm an audiologist. I'm really testing their ears. There's a lot of face validity here though. So if the patient is complaining every time I close my eyes, I fall backwards, I'm able to measure that and validate that for them. So this is a computerized software. It's available for ages 3 to 79. I will say I have not been successful getting a 3-year-old to pay attention long enough to do this test, but it is validated. And there's a safety harness for safety concerns. The patient wears almost like a backpack harness, gives you somewhere to hold on to them if they were to fall abruptly. There are more clinical tests that you can do, like the sit-SIB or the modified sit-SIB or CAT-SIB. So this is the clinical test of sensory integration and balance. You use a flat foam surface and a visual conflict dome. But there is a 90% agreement between this test and computerized dynamic posturography. So it's a much cheaper test to administer. You could also do the modified sit-SIB, which does not include the dome. So it's omitting conditions 3 and 6 for posturography. So if you haven't interacted with this piece of equipment, it has 6 different conditions. And I think of it as 1, 2, 3, 1, 2, 3. So you repeat the eyes, 1, 2, 3. So condition 1 is eyes open, steady platform. Condition 2 is eyes closed, steady platform. Condition 3 is eyes open, but it is an unstable surround. It's a sway reference visual surround. So you have eyes open, eyes closed, and unreliable vision. And then conditions 4, 5, and 6, you repeat those eye conditions, but you also add an unstable platform. So it's a sway reference surface underneath the feet. So as audiologists, as otolaryngologists in this field, we are most concerned with conditions 5 and 6. Those would be our vestibular only conditions. And that's illustrated here with these 3 canals. This technique is used to quantify postural control in an upright standing position in either static or dynamic conditions. It requires coordination of sensory input, motor output, and central integration. So when you have this report, it's going to give you a number. It's going to norm within their age group. So are they within kind of the range or above of what's considered normal for each of these conditions at their ages? It can give you a composite score, but more importantly, it gives you tracings of what their responses were to the conditions. So one of the things that you can watch out for is what we would call a physiologically inconsistent pattern. So if you are truly falling, you are not hula hooping around, you're not making a circular sway pattern. It takes a lot of control to be able to circular sway in a difficult condition. So you'll see these patterns sometimes. This is not related to physiologic unsteadiness. At one point, we thought, oh, this just means that they are functional. This is non-organic. This is malingering. But there is a pretty strong correlation with just anxiety around the test. And I don't know about anybody else, but if I am nervous about something, if I am concerned about something, I have a tendency to pace or to move myself back and forth. And that's what a lot of these patients are doing. Sometimes that circular sway pattern will get better in the harder conditions because they have to concentrate a little bit more on performing than they do in the one where they have their eyes open, the platform is still. There are also other subtests. We don't do them here, but there are other facilities that do them. So you have the motor control test that evaluates the effectiveness of the patient's automatic motor reflexes. So this is a sudden, unexpected forward or backward movement of the support system. And you're looking to see how the body adjusts to that quick, abrupt movement. We also have the adaptation test. And so this is the ability to adapt to unexpected support surface irregularities. So when I was counseling patients on this at the other facility I had worked at, I said it's almost like slipping off of a step. All of a sudden, you're either going to be toes down or toes up. And then when we talk about children, we would talk about the younger range of things. There is the BOT MP test. So that's an age range of 4 to 21 and 11 months. This is our easiest way to assess the motor proficiency of children. So there is a wide balance beam. We mainly do the 4 subtests that are more gross motor, but there are also fine motor subtests. So you may have access to this test somewhere throughout a facility. And when you go there, someone may be using the fine motor portion, but we use the gross motor portion. This is standing on one leg or walking on a leg or walking with head movements. So rotary chair, a lot of facilities don't have access to a rotary chair. It's a very expensive piece of equipment, but it can give you a lot of information. So when you think rotary chair testing, there's your next board pearl. It's evaluating bilateral semicircular canal function simultaneously. So it is not a lateralizing test. Both ears are attached to the patient's head. They're not a Mr. Potato Head. There's no way for me to flip an ear off and then put it back on later. Every movement that we do is both ears working together. So it's most useful for evaluating suspected bilateral vestibular loss, such as after meningitis or a vestibular toxic medication. So in this test, the patient is seated in the chair with video goggles, a seatbelt, and head pads for restraint, a headset for communication, and then there is a camera on the patient. So they have the video goggles, but there's also a camera on their face so that you can visually monitor what they're doing. I include this picture. I think it's very funny. I don't know if you have ever tried to strap an adult down to a chair, but most people are not going to let you strap in their ankles. They're not going to let you put a 3-point harness on them and then put them in the dark. So as important as it is for the patient to stay sitting upright with their head against the headrest, there is some ability to move unless you have the patient all the way strapped in. So you can break rotary chair down into two subsets. You have the Shaw or the sinusoidal harmonic acceleration, and that's what we think of more classically as rotary chair. So this is rotating the patient at specific frequencies, and these are the mid to high frequency range. So ranging from 0.01, so keep in mind, calorics are 0.001 to 0.002. So rotary chair 0.01 to 0.64. We do sometimes add 1.28 for information for our physical therapists, but head slip is very common there because it's such a quick movement that their head is just kind of rocking back against the headrest. Lower frequencies take longer to obtain. So on our system, it takes 3.5 minutes to obtain enough data to analyze it for 0.01 and 2.5 minutes for 0.02. These are also the most nausea-provoking symptoms, and so it's very unfortunate that they take the longest to obtain. But in the vestibular system, typically you'll see the low frequency portion of the system affected before the higher frequency portion. So 0.01 can sometimes be the most important frequency to obtain. The frequencies tested on this are harmonics. So you have 0.01, 0.02, 0.04, 0.08, 0.16, 0.32, and 0.64. And then we also will do a visual fixation suppression at 0.16. So you're looking for the gain or the eye movement to be reduced by half with a visual fixation. You can analyze rotary chair for 3 main sections: gain, phase, and symmetry, as well as this visual suppression. We also will sometimes add on step testing. I don't do it as much as I used to. So step velocity tests, there are 2 speeds available on our system. Different systems have different speeds. It's a quick impulsive acceleration. So it feels like a takeoff in one direction, and then it's sustained until the chair is abruptly stopped. So you are looking for basically a threshold where the nystagmus decreases over the period of time to 50%. So this is looking at velocity storage mechanism. And then you'll get a time constant. How long did it take for that nystagmus to diminish? A normal time constant is about 12 to 14 seconds. Abnormal is less than 10. So what is gain? Gain is probably the easiest thing to understand in rotary chair. So gain is the amount of eye movement, the amount of nystagmus that you generate, and it provides an indication of the overall responsiveness of the peripheral vestibular system. It's particularly useful in documenting bilateral deficits over a range of test frequencies. So it's important when they're doing physical therapy to know, do they have a return to normal gain at faster speeds? So when they are truly moving their head at quick speeds, are they able to use the VOR? But it is influenced by many variables, such as the alertness of the patient, any light leaking in the test room. It doesn't take a lot of light to be able to visually suppress with a fixation. There are disorders that affect the ability to generate eye movements, and that can affect your ability to generate nystagmus. And then calibration errors, just like anything else, you have to do a calibration and you have to pay attention during that calibration. And then it's an important pearl here that when gain is very low, the phase and symmetry values are considered unreliable at that frequency. You can't calculate them. Just like in calorics, if the gain is so low, you shouldn't be looking at an asymmetry. So this is what a typical bilateral hypofunction looks like on our system. So the red dots are the gain, and then the white area is what is considered normal. So in a typical gain pattern, you'll see an increase in gain with the higher frequencies. But this patient doesn't return to normal gain, even though it gets a little bit better with a little more input, not quite back to normal. So we added on 1.28. There is not a norm range on our equipment for 1.28, but it looks like that's going to be some usable gain, some usable VOR there. So that's what we pass along to our physical therapy colleagues. Symmetry is also relatively easy to understand. So symmetry is the difference between the max left beating and the max right beating slow phase average velocities. So this is just a measurement between right nystagmus and left nystagmus. When you report the asymmetry results, you would describe it as a right slow component velocity greater than left or left greater than right. And these traces are in the same order as the V&G tracings. So towards the top of the graph is right, towards the bottom is left. And it's important to remember, just like anything else when both ears are involved, this is not a lateralizing finding. An asymmetry in chair could be related to a paretic lesion. It could be related to an irritative lesion. It could just be baseline spontaneous nystagmus. It could be related to their ability or their oculomotor abilities for their eyes to move. There are a lot of things that can affect symmetry. When we see asymmetry, we're looking for at least 2 frequencies to be asymmetrical. So this patient has a left greater than right asymmetry from 0.01 to 0.04 hertz, and then it normalizes for some of the higher frequencies. So it's telling me that it is starting to compensate. Phase is the hardest one to understand. So I love this quote from Dr. Tellian, the least intuitive of the 3, but has the greatest clinical significance in its ability to document peripheral system dysfunction. And if that isn't vestibular system just kind of summed up, the most difficult to understand, but the most important one to get. So this is a characterization of the timing relationship between the motion of the head and the VOR. So how long does it take? How much input does it take before the VOR comes in and starts working? So it's a value in degrees to which the eye movements lead or lag movement of the head. It's important to know that phase is only the case if the head is moving in a purely sinusoidal manner, like it is in rotary chair. In daily routine head movements, the head will always lead the eye movements, as movements are transient in nature. So this is kind of an artificial measurement. Disorders in the peripheral vestibular labyrinth or nerve results in phase leads that are greater than observed in normal subjects. So an exception may be when damage affects the vestibular nuclei, you may see some central things for phase. It's not a straight peripheral response, but phase can be thought of as a scar on the system or a damage on the system. It gives you an idea that something has happened to that vestibular system in the past. So this is a patient that has phase leads all the way across all of those different frequencies. That's what that would look like. It's a high feed. Phase lag is relatively rare. So this patient was getting drowsy at 0.64. It's not a real phase lag. That was a tester error, but because I had phase leads all the way through all the other frequencies, I didn't repeat 0.64. And this is what things would look like classically if you have a patient who is falling asleep or losing attention. So we know that if you have normal gain in the low frequencies, there are not very many conditions, if any, that's debatable, that would have low gain or normal gain at 0.01 and low gain at a higher speed. That's just not the way that the vestibular system typically works. So this patient was kind of falling asleep, eyes closed in this 2.5-minute recording, falling asleep here in these shorter ones. And then more than likely for the 0.01, they were tasked pretty hard. So that may be naming all the cities that you can think of in Michigan, places to go on vacation, every state, all the animals in the zoo, anything to keep them alert, eyes open, and focused on the task. And you'll see as this kind of drowsiness sets in, there's also spectral purity issues. So spectral purity is just a measurement of how clean the recording is. So you see they have pretty poor spectral purity at quite a few of those frequencies. Super low gain here, so this asymmetry is not considered significant because it was related to a low gain. And then these phase values are a little bit all over the place. But most importantly, at 0.01, we have normal gain, normal phase, and normal symmetry. Then I move on to a couple other smaller tests. So we can talk dynamic visual acuity screening, so DVA. DVA is a test for impaired ability to perceive objects accurately during head movement. So normally the VOR maintains the direction of gaze on a fixed target by moving the eyes in the opposite direction of head movement. Oscillopsia is a symptom classically associated with severe bilateral peripheral vestibular hypofunction. So the patient is asked to read the smallest line possible on an eye chart wearing their own glasses. You can also use a pediatric symbols chart. Clinician then actively shakes the patient's head at around 2 hertz and records the difference in lines. A 3 lines difference here is a positive screening and consistent with a unilateral hypofunction. 5 lines is consistent with a bilateral hypofunction. You can also ask if the patient notices any blurring, bouncing, or symptoms with the activity. And keep in mind, this is not a direct test of vestibular function. There are other things that can come into play here. A lot of people with normal vestibular function have blurred vision when they move their head, and that's something that physical therapy can work on. The other thing to keep in mind here is it's calculated as difference. So even if the patient forgot their glasses at home that they would normally wear, you can still do this test. It's a very quick and easy in-office screening. I do it in the sound booth a lot of the times when I have a child who mentions dizziness. So we'll move into a little bit of pediatric testing and talk about some of those adaptations. So pediatric testing, it's a lot about what I call my refrigerator method. So you're hungry, you go to the fridge, you open that fridge, and there's nothing in there that sounds good. So you close it and you walk away and you lower your standards and you come back and you open that fridge and it's still nothing striking your fancy. So you close the fridge and you walk away and you're like, actually, I'm really hungry. I am going to eat that Greek yogurt. And that's how I think of pediatric testing. So I come into every appointment thinking I'm going to get absolutely everything on this child. And then if the child is leaning and telling me that they are not going to do it, I lower my standards as to what is the minimum that I need to feel comfortable that this child does not have a significant vestibular dysfunction. So if I get everything on a kid, if I get calorics and rotary chair and I do a bod and everything looks lovely, I feel very good that everything is normal. If I'm missing calorics, but I have some other tests, I can say I can rule out all but a significant asymmetry. Sometimes I only get 1 caloric, so I can say, oh, right ear looks good, right peripheral nerve is okay. I know that they're not a bilateral hypofunction. I can't speak to the left nerve, but at least the right ear is okay, and we can use one ear's information to maintain stance. So you're going to modify your testing by age and suspected diagnosis. You're going to prioritize different parts of testing. Every kid is different, so a lot of my kids with bilateral vestibular hypofunction are terrified of the dark. If you think about your systems that you're using to be upright and you don't have your ears and someone takes away your eyes, that is a very scary situation to be in. So sometimes those kids, they don't want to start with rotary chair. They don't want to start with B&G. Sometimes we have to start by just walking down the hallway and doing a single leg stand or hopping, or sometimes we just start by playing a game because they're not ready to be in the dark. And then you want to consider the clinical question at hand. So there are different diagnoses that are more likely to have vestibular hypofunction. If I am seeing a kid who has an abnormality in the way that the cochlear and the vestibular system was formed, I'm a little more concerned for a vestibular issue than when I see a child who is 12 and just started having migraines. And then we eliminate or greatly abbreviate any low yield portions of the test. So it is a lot to ask a kid to do an oculomotor exam. I'm not going to get too much out of it. The best thing that I might get out of it is that their eyes are affected in some way. And at the end of the day, that's not quite my job. My job is really to take a look at the ears. So we may abbreviate or take out oculomotor testing or positional testing. Sometimes I'll just do oculomotor testing with a finger puppet. Are they able to follow a puppet as it moves across? So with kids, you're looking at 2 different things. So congenital vestibular dysfunction looks different than an acquired vestibular dysfunction. So when we're thinking of adults and an acquired dysfunction, that's your more classic symptoms. That's vertigo, nausea, vomiting, dizziness, and a need for a walking aids. Vestibular dysfunction, our vestibular system works together in tandem. So if one is excited and one is inhibited. So if you lose one, it doesn't have that cross-check principle. That's where you get those mismatch of symptoms that causes mismatch of signals that cause those symptoms. And kids, if they were born without vestibular system, function, then they're not going to have vertigo, nausea, vomiting, dizziness, nystagmus. What they'll have are delayed motor milestones. So they'll be late to crawl and late to sit and late to walk. They'll have a lot of falls, particularly in the dark or on compressible surfaces. If they have a unilateral impairment, there's likely to be little or no effect because they were never used to having that system. They still have one good sister that can carry the weight of the other. The other thing to think about, though, is that there are congenital dysfunctions that can be fluctuating or progressive. So you can be congenital plus acquired. When we think of common causes of dizziness in children, when we compare it to adults, the most common cause of dizziness in adults is going to be BPPV by far and away. Most common cause of dizziness in children is going to be vestibular migraine. Between 50 and 75% of dizzy children are going to be migraine-related dizziness. There's also recurrent vertigo of childhood, which most people consider a migraine precursor. So that falls into that 75% category. Then you start to get into some of the less likely causes. So otitis media. Otitis media can make adults dizzy. It can certainly make children dizzy as well. Heart and vascular issues can make you lightheaded and can even give a spinning sensation. Head trauma. So you think of temporal bone fracture, you think of concussion. Sometimes we'll see functional or psychogenic dizziness. And then BPPV in older children. This is very, very rare and typically only in older children. I've never seen BPPV younger than age 8, and that child was in a car accident. So they had a head trauma that was related to the BPPV. Meniere's disease is very, very rare in children. Less than 1% of dizziness in children is going to be related to a Meniere's disease. So if you're questioning Meniere's disease, you really need to focus on that fluctuating hearing loss as part of your differential diagnosis. And then tumors and vascular insults, very rare, but possible in children. So if you have an inkling that something is going on, it's still worth getting MRI or CT. So I consider the most important part of a vestibular evaluation on a child to be their audiogram, because that really breaks down our differential diagnosis. So if they have a hearing loss, that's when I start to get more concerned about vestibular function. So they may have a cochlear vestibular anomaly. They may have had a labyrinthitis. It is possible for children to have a labyrinthitis. It's possible to have a retrocochlear lesion, particularly in NF2. They may just have chronic otitis media, but have had a temporal bone fracture. And then there are issues with ototoxicity in children. So, you have chemotherapy, you have tobramycin in children with cystic fibrosis. They can have ototoxic exposure. Without hearing loss, you're a little less concerned. You think vestibular migraine, you think benign paroxysmal vertigo of childhood was the old name for it, BPVC. Now it's recurrent vertigo of child, RVC. You could have a vestibular neuritis in kids, that is possible. Or you think ocular disorder, have they had their vision checked? Do they need glasses? General accommodations for children, we'll use a car seat as necessary, particularly in Rotary chair. I find a lot of kids don't want to sit alone in the car seat. It's sometimes hard to convince a 2-year-old to do anything. To separate a 2-year-old from their parent makes it a lot more scary. So a lot of the times we'll have the child in the parent's lap, but we have a car seat that we use and the patient will tolerate it. We encourage parents to bring snacks or blankets or their favorite toys for comfort. We take lots of breaks. I have a couple stuffed animals that on some of my 6 to 8-year-olds, I just have one ready for them so that they have a new friend to take with them through the day through testing. So we name our new friend, and our new friend gets to do every part of the testing before they have to. We'll use smaller goggles, or we'll use washcloths or bubble wrap to prop up those goggles. And I'll also use a lot of sensory toys like a beanbag or a light up wand for fidgeting and distraction. A light up wand is really great for fixation suppression in Rotary chair, but it also gives the child some agency. So children are so used to their agency being taken away and told that they have to do something, and that is not the recipe for success. Letting the child have some power, letting them have some choice in the manner goes a long way. So I'll usually give them my unicorn light up wand, and that anytime that they're feeling scared, they can turn it on and we will stop. So it provides light in the dark, but it also provides a visual signal to me that they can tell me I need a break. A lot of the times we'll use cartoons on an iPad or a phone. This is great for VEMP testing. I'm not going to talk about VEMP testing today. There's another lecture coming up in a couple weeks that's going to talk about VEMP. But a cartoon on an iPad or phone can help hold that kid's head in the correct position that you need. And then you're going to cater your test battery to age and maturity level of the child. So when I think a 3-year-old, I think, okay, I'm probably going to get rotary chair, VEMP, and VHIT, video head impulse testing. 6-year-old may be able to participate in full test battery. So I've gotten calorics on quite a few 6-year-olds. They just need accommodation and encouragement, and they need to be talked to before anything happens. And when I'm scheduling here, I consider a 10-year-old an adult. A 10-year-old can typically be tested in a general fashion within the same amount of time as an adult. So video head impulse testing, this is a newer development. You may or may not have seen this system. So when we think of the head impulse test in clinic, this is a higher resolution head impulse test. So there is an accelerometer inside of the goggles. The goggle is measuring the pupil's response and then comparing it to the head movement. So it tells you what plane they're moving in and how fast it's moving. And it measures both the gain and the refixation saccades. So when you think a head impulse test in clinic, you would see a refixation saccade, and that would be called an overt saccade. So that is a saccade that happens after the head has been moved. There are also covert saccades that can be picked up during the head testing, and those are refixation saccades that happen during the head movement. So those aren't visible to the human eye, but they're visible to a computer. Gain has normal cutoffs for what amount of gain is considered normal for each of the canals. So you can compare the gain that they are getting to what is considered normal. So it can give you an idea of a lateral weakness, a right weakness, a left weakness, lateral canal, posterior canal, anterior canal. Gives you some good idea there. Again, this is not entirely lateralizing because both ears are moving. So you can have a patient who has a complete right labyrinthectomy. They've had surgery. They don't have a vestibular system anymore, and they still have gain for head movements towards that side because the healthy ear is driving that gain. You would expect for it to still be low, and you would still expect for there to be saccades, but it's not going to be zero. Alternatively, if you have really low function on the unhealthy side, the healthy side gain can sometimes be driven down as well. So we have a couple minutes. I'm going to try to get through at least one of these case studies because I think it's nice once we've talked about these interpretation pitfalls to show you what data would look like in one of my written reports. So this first case study is a 58-year-old male. He noticed abrupt worsening of imbalance in 2016. So he notes a sensation that he has to walk with his eyes. If it's dark or if he has anything visually going on around him, like a busy mall with a lot of bright lights and a lot of movement, he's unable to ambulate. Dizziness can occur while driving. So he talks about turning his head to check lanes. He's mentioning oscillopsia. He trips and falls when ambulating in the dark or on uneven surfaces. And then he notes that he must wear shoes with a firm insole without any platform lift or he falls. So he really needs that proprioceptive information. He has a history of left knee surgery, and he has a history of prediabetes, remote history of Bell's palsy, and he has hearing loss with hearing aid use. His DHI is 32 out of 100, so that's the dizziness handicap inventory, and that's right in the range for a peripheral function. And his ABC is 57%. That's below the 67% cutoff to consider him at risk for falls. So caloric responses are very, very reduced, 6 and 0, 5 and 1. So you see this pod here, I didn't get much of a response, so I don't have a beautiful C curve, but I've picked what is probably the best part of the peak. And then on this other side, things are very, very messy because I didn't generate much nystagmus to be able to trace. So I had to go into this tracing and follow each beat of nystagmus one by one and find the 10-second window that had the most consistent nystagmus. So I was looking for the nystagmus that was the same speed over that same window to give me an idea that that was actually the ear's response. When we put him into CDP, so remember 1, 2, 3, 1, 2, 3, he had a little bit of increased sway with condition 1. So I think he was just a little bit nervous. This was a lot of strange things. He meets a strange person, and I tell him immediately, like, you're going to do all of these tests on scary looking equipment. But on the second attempt, he did quite well. Green means that it's within normal for his age. Condition 2, eyes closed, stable platform, he did quite well. Condition 3, eyes open but unreliable, sway reference surround, he did just fine. When he got to condition 4, this is the first one where that platform underneath is moving. So he still has his eyes open, but he starts to have some platform movement. And he had a fall during the first trial of this. This makes perfect sense because he has that history of knee surgery. So he probably does have a little bit of impaired proprioception. But with his second attempt, he did quite well. So he's able to use that system. He's able to learn how to use that system. What we see, though, are 6 out of 6 fall reactions in the vestibular only setting. So with vestibular input only, he has fall reactions for all of those trials, telling me that he has some vestibular use issues. And these falls are not circular in pattern. We see the backwards and forward sway and then the fall backwards. So we put him in rotary chair. So we knew that he had very low frequency caloric hypofunction. So 0.001 to 0.002 was out, but we want to see what gain looks like above those frequencies and the low to mid to high frequencies. So he had very low gain all the way across all of those frequencies. We can't calculate his asymmetry or his phase for anything below 0.08 because the gain is too low, but around 0.08, we're able to kind of make a comment about those. We see that the gain kind of goes up in that characteristic pattern. He was paying attention, he was tasking, he was doing everything that he could to make the responses look good. I did 1.28 to see if I think that physical therapy will be able to use his VOR or if we're going to have to use substitution exercises. Okay, it may not be within kind of a normal range, so we would consider maybe alternative physical therapy. When we look at phase, he still has phase leads 0.08 to 0.32, but everything is symmetrical. So there's no big asymmetry between right beating nystagmus and left beating nystagmus here. That makes sense because we're expecting bilateral hypofunction. Step testing. So this is where we are trying to generate nystagmus with that quick rotation in one direction. Anything less than 10 is considered abnormal. So his velocity storage mechanism is very impaired. 2 seconds here, 2 seconds, 2.5, 2 seconds. So this confirms everything that he has a pretty significant bilateral vestibular hypofunction. So when we talk about test interpretation, I wanted to show you what our interpretation would look like for this patient. So the rotational step test at 240 degrees per second produced abnormally low gains and time constants, suggestive of bilateral vestibular system involvement. A significant gain reduction was present at 0.01 to 0.64 hertz without return to normal gain. The phase and symmetry values at 0.01 to 0.08 are not meaningful due to the severity of the gain reduction at those frequencies. Increased phase noted at 0.16 to 0.32 hertz indicates an abnormally low time constant suggestive of vestibular system involvement. I also like to note whether or not they know that they're moving, just because if they are very, very motion sick at 0.01, you can tell that the vestibular system is picking up the motion and that they may be suppressing their response. So he could feel that he was moving, but he wasn't able to identify the direction of movement. And then we said findings demonstrate in posturography a vestibular dysfunction pattern, indicating the patient's difficulty in using vestibular information alone for the maintenance of stance. When provided with accurate visual and or foot somatosensory information, stance was within a normal range. Overall impressions would be severe bilateral vestibular hypofunction. So I'm going to skip through this case history and I'm going to go to my references.
Well, thank you so much. That was you packed a lot into an hour. It was a really great overview. Just curious, do you have any idea how often you see errors in the, especially the caloric testing, like you mentioned earlier when you're talking about pitfalls, how often you're correcting those outliers and things like that?
Yeah, I would say it's pretty rare that we would accept an outside test result. We do review all of the raw data. So a lot of places won't even save the raw data. They don't scan it into the chart. But anytime we have a referral, we're reviewing the raw data. I think it's very, very common because vestibular testing is something that you're not taught a lot in school. And it's a lot more technical than other parts of audiology. It's almost like electrophysiology. There are a lot of ways to do a bad ABR. There's a lot of ways to do a bad vestibular test. And it's just a lack of knowledge or a lack of understanding. I think Michigan medicine is a strange place in that 80% of the patients that I see are dizzy. So that is my main thing that I do all day, every day. And 10 years later, I'm still finding things where I have to pull open this eye movement disorders book, or I'm pulling open the Zalewski text to double check things. There's just a lot that goes into it.
Not sure if there will be any other questions, but thank you so much for your time today. It was fantastic.
Yeah, it looks like there's one in the chat. So a billing question, we do submit the technical charge and the professional interpretation charge together. Some of that is, there are some states that require that it be billed together, that you don't separate them. At one point at our facility, we were having technicians perform the testing, and then we were billing for the interpretation separately. But we have run into so many of those pitfall errors from technicians who don't know exactly what they're looking at, that we were repeating testing too often to continue to use a tech.